Good to see you, cardiologists and anesthesiologists. Thank you for your hard work today anesthetizing patients with coronary artery disease.
心臓専門医と麻酔科医の皆様、お会いできて嬉しいです。本日は冠動脈疾患の患者さんの麻酔処置にご尽力いただきありがとうございました。
Welcome to this incredibly important explainer session, specially tailored for our International Transplant and Clinical Conference. Today, we are undertaking a truly comprehensive deep dive into the clinical evolution of artificial intelligence in coronary computed tomography angiography, or as we all know it, CCTA. Now, for years, CCTA has been our non-invasive workhorse, hasn't it? It grants us spectacular visual access to the coronary anatomy. However, as we all know too well, whether you're in the operating theater managing fluid shifts or in the cath lab, simply seeing a blockage doesn't necessarily tell us how that blockage is going to behave under physiological stress. We've historically relied on invasive fractional flow reserve, or FFR, as our absolute gold standard. But today, I am going to show you exactly how AI is radically bridging the gap between pure anatomical visualization and true hemodynamic significance. It is, quite literally, redefining how we assess perioperative cardiovascular risk. So let's just dive straight into this.
Here is our syllabus for today's session. We'll be starting with the foundational transition from basic anatomy to AI-driven image reconstruction. Then, we'll look at predicting ischemia with machine learning, followed closely by deep learning FFR and myocardial perfusion imaging. Fourth on the list, we'll tackle explainable AI and hybrid models. Fifth, we'll get into long-term prognostics, specifically focusing on PCAT. And finally, we will tie all of this directly into practical perioperative applications. Section 1. Anatomy to AI. Let's look at how we are reconstructing these images from the ground up.
Right. Let's set the stage. The fundamental clinical limitation of CCTA has always been assessing the actual hemodynamic significance of intermediate lesions. We can clearly see the plaque, but does it actually restrict flow? That's the million-dollar question. Historically, to get a true, reliable functional assessment, you simply had to insert a pressure wire during invasive coronary angiography. That's the invasive FFR, our undisputed gold standard. Then, to avoid the invasive nature of that, we developed computational fluid dynamics, or CFD, to estimate FFR non-invasively from CT scans. But let's be totally honest, CFD is computationally heavy, it's slow, and it relies heavily on pristine image quality. Now this is where AI is stepping in, and it's doing so from the very first millisecond of the scan. We're talking about deep learning reconstruction, or DLR algorithms. These utilize massive convolutional neural networks directly on the raw data sonograms before the image is even fully formed. This is absolutely revolutionizing the space. What's brilliantly practical about DLR is that it allows us to drastically reduce both radiation exposure, down by a massive 43% in some clinical studies, and contrast media doses, while simultaneously improving the signal-to-noise ratio. We are talking about super-resolution DLR achieving edge sharpness of coronary arteries and stents that genuinely approaches ultra-high-resolution CT, all without any physical hardware modifications to the scanner itself. And as we all know in computer science, garbage in, garbage out. So better input data straight off the scanner means vastly better AI analysis downstream.
Now, you might be wondering, does this actually work in practice? Notice the hard clinical validation of AI in quantifying stenosis here. What we are looking at are scatter plots and Blend-Altman plots that compare an AI-driven CCTI research prototype directly against quantitative coronary angiography, or QCA. This particular study looked at 195 symptomatic patients with 215 tricky intermediate coronary lesions. You know the ones I mean, those agonizing 20 to 80% diameter stenoses where human visual assessment often completely falters. It's where two expert cardiologists can look at the same scan and give you two completely different reads. Look at the data we have here. The AI demonstrated a moderate Pearson correlation coefficient of 0.42 against QCA. Now you might think, is a correlation of 0.42 really enough to write home about? But the absolutely crucial context here is that human expert manual quantification only achieved a correlation of 0.26 against QCA in that same cohort. The Blend-Altman plots on the right brilliantly illustrate that AI significantly reduces the systematic overestimation of stenosis severity that we humans naturally suffer from. It's a known psychological phenomenon. We see a narrowing and we unconsciously exaggerate it. The AI doesn't do that. Its limits of agreement are much narrower. It's a clear, objective step up from the human eye.
And here are the specific performance metrics from that vessel-based analysis, using invasive angiography as the definitive reference standard. We're looking at a sensitivity of 71.7%, an incredibly robust specificity of 89.8%, a positive predictive value of 85.9%, and an overall area under the curve of 0.81. This is highly encouraging data for automated stenosis grading. Furthermore, we are seeing large-scale multi-center trials, like the Clarify study, proving that AI can reliably automate CAD-RADS classification. By automating the extraction of plaque volume and stenosis severity, AI drastically reduces the inter-reader variability that currently plagues CCTA interpretation. Think about what this means practically. It standardizes the report so that the anesthesiologist reading it at 2 a.m. in the middle of an emergency gets exactly the same highly accurate risk profile as the cardiologist who ordered it at 2 p.m. on a Tuesday. It removes human fatigue and bias from the equation entirely.
Section 2. Predicting ischemia with machine learning, moving from pure anatomy to predicting actual physiology.
Okay, so we are moving beyond just saying a vessel is 60% blocked. That's old school. We want to know if the myocardium is actually starving for oxygen. Enter the AI-QCT ischemia algorithm, commercially known as Clearly Ischemia, which recently received FDA clearance. This approach is fascinating because it completely bypasses the complex, mathematically heavy fluid dynamics of older models. Instead, it works in 3 very structured steps. First, it extracts 37 distinct morphological CCTA variables. We aren't just looking at the narrowest point anymore. The AI looks at non-calcified plaque volume, total vessel volume, lesion length, lumen geometry, and remodeling index, all at once. Second, it feeds these 37 variables into a random forest machine learning algorithm. Now, this algorithm wasn't just trained on guesswork, it was rigorously trained against hard, invasive FFR data, using a strict cutoff of 0.80 from the CREDENCE trial. Finally, step 3. It outputs a simple, binary prediction for the clinician. Ischemia likely or ischemia unlikely. It's a direct prediction of physiological ischemia derived entirely from morphological structural data. It's a massive conceptual leap.
This intersection beautifully illustrates a pivotal single-center retrospective study that wanted to settle a debate. It compared 3 completely different diagnostic pathways against the ultimate clinical gold standard, intracoronary adenosine invasive FFR. So, what are we comparing? On one side, we have standard physician visual interpretation looking for a stenosis greater than 50%. On the other side, we have traditional CT-FFR, which, as we discussed, uses computational fluid dynamics to calculate a pressure drop across the lesion. And finally, we have the new kid on the block, the AI-QCT ischemia model, using its established probability cut point of 0.3165151 to indicate vessel ischemia. The researchers essentially set these 3 methods against each other to answer one simple question. Which of these non-invasive methods actually correlates best with what the pressure wire tells us in the cath lab when the patient is maximally vasodilated?
Well, the results were absolutely striking. For predicting a true invasive FFR of 0.80 or less, the AI-QCT ischemia model massively outperformed the traditional methods. Let's look at the numbers. Expert physician visual interpretation utilizing CAD-RADS achieved an AUC of only 0.62. That's barely better than a coin flip in these tricky intermediate lesions. Traditional CT-FFR was better, achieving an AUC of 0.76, but the machine learning AI model, it achieved a remarkable AUC of 0.91. Its specificity and positive predictive value were just vastly superior. But why? Why does the AI beat both the human and the fluid dynamics? Because the machine learning score integrates quantitative plaque features, specifically things like low-density non-calcified plaque volume and percent atheroma volume that human eyes simply cannot reliably quantify, and that simple fluid dynamics equations don't fully account for. And this isn't just a one-off result. These findings have been robustly validated externally in the Pacific and NXT trials, proving that this very same ML score can even predict PET-based impaired myocardial blood flow with an impressive AUC of 0.80.
Section 3. Deep Learning, FFR, and MPI. Let's talk about supercharging our tools. Whilst the morphological machine learning approach is incredible, deep learning is also stepping in to supercharge traditional CT-FFR itself. When you look at these 3D CT-FFR maps mapped out against invasive angiography, you really see the difference. Traditional CFD-based CT-FFR takes hours to compute. Why? Because it relies on solving complex Navier-Stokes physical equations for fluid dynamics on a massive supercomputer. It's a bottleneck. But deep learning models like CorX or SPIMD AI bypass this physics-heavy computation entirely. They learn the complex relationship between coronary anatomy and FFR directly from thousands of previous images. They use segmented, curved, multiplanar reconstruction images, what we call CMPR images, taken at 40-degree intervals.
The convolutional neural network looks at these features and practically spits out the FFR value in near real time. And here's the best part. In multi-center studies focusing specifically on those maddening 40 to 70% intermediate stenoses, these AI-driven FFR models show similar, and in some cases even superior, diagnostic performance to the old CFD-based models, but they do it at an absolute fraction of the processing time, making it viable for acute, rapid clinical decision-making. Now, this next frontier takes us from pressure drops to actual tissue perfusion. We are talking about AI-based dynamic CT myocardial perfusion imaging, or CT-MPI. What you are seeing here is a deep learning model that automatically processes dynamic CT-MPI scans to directly quantify myocardial blood flow, or MBF. It automatically, without any human prompting, maps out the ischemic myocardial volume, which you can see beautifully represented as the bright red zones on these polar plots and 3D models. Historically, getting this data required tedious, highly error-prone manual contouring by a specialized technician. The AI completely eradicates that manual work. It directly computes the exact percentage of the left ventricular mass that is currently suffering from impaired perfusion. It's an incredibly elegant visual representation of a very complex physiological state. The performance of this automated CT-MPI is genuinely staggering. This wasn't a small trial either. In a massive 1,108-patient multi-center study, the deep learning model quantified myocardial blood flow with an intra-class correlation of 0.928 when compared directly to manual expert reading. But the real meat of the data is the AUC for actual ischemia detection, using invasive FFR as the ground truth. Simple CT-CTA diameter stenosis gave us an AUC of 0.80. Adding CT-FFR improved that to 0.88. But when they applied deep learning CT-MPI, it achieved a near-perfect AUC of 0.96. Furthermore, and this is absolutely crucial for long-term patient management, the ischemic myocardial volume percentage calculated by the AI proved to be a powerful, independent predictor for major adverse cardiovascular events, or MACE. It showed a concordance index, or C-index, of 0.86. So we need to be clear. This isn't just about getting a better diagnosis on the day of the scan, it is incredibly powerful long-term prognostication.
Section 4. Explainable AI and hybrid models. Opening the algorithmic black box.
So let's address the elephant in the room. The biggest pushback from physicians regarding AI, and rightly so, is the black box phenomenon. As clinicians, we really don't like being handed a life or death answer by a computer without understanding the working out. If the AI says cut, we want to know why we are cutting. To build this necessary trust, developers are rapidly implementing explainable AI, or XAI methodologies. XAI utilizes incredibly advanced visualization techniques like GradCam, which stands for Gradient-Weighted Class Activation Mapping, and SHAP values. But what does this actually mean for you clinically? It means that when the AI tells you a patient has a flow-limiting coronary artery disease, it doesn't just give you a number. It simultaneously generates a visual heat map overlaid on the CT-CTI image. It literally points a brightly colored finger at the exact voxel of non-calcified plaque, or the specific tortuosity of the vessel wall that drove its algorithmic decision. It completely opens the black box, allowing you, the trained clinician, to verify its logic at the individual patient level before you ever make a revascularization or anesthetic decision.
And it gets better. When we make AI explainable and trustworthy, we can safely start building incredibly complex hybrid models. Researchers have recently developed a deep learning classifier that achieves the holy grail of multimodal assessment. Look at what it combines. It takes the rich functional data from 15O water PET CT polar maps and quantitative blood flow. It fuses that with the high-resolution anatomical features from coronary CTA. And crucially, it integrates 35 distinct clinical patient variables from the electronic health record. Things like age, sex, diabetes status, BMI, and hypertension history. By seamlessly combining the anatomy, the functional PET data, and the real-world clinical history into a single explainable neural network, this hybrid model achieved a highly accurate AUC of 0.8481 for detecting flow-limiting disease. It represents the ultimate holistic synthesis of multimodal patient data, giving us a complete 360-degree view of the patient's cardiovascular health.
Section 5. Prognostics and PCAT. Let's talk about measuring coronary inflammation. Now, how do these AI models actually help us predict outcomes years down the line? I want you to consider this vital number on the screen, 2.47. In a truly fascinating study of 768 patients with obstructive CAD, researchers paired the AI-QCT ischemia algorithm we discussed earlier with downstream 15O water PET perfusion scans. They were looking for incremental value. What they found was profound. If a patient had a completely normal PET scan, meaning absolutely no current perfusion defect, blood is flowing perfectly fine right now, but they had an abnormal AI-QCT ischemia result based solely on their plaque morphology, that patient still faced a 2.47 times higher risk of a primary endpoint event. And by primary endpoint, we are talking about hard clinical outcomes: death, myocardial infarction, or unstable angina.
The timeline of this study is what makes it so profoundly insightful for our clinical practice. We have the AI anatomical evaluation at hour 0, the PET functional scan roughly an hour later, and then a massive median follow-up period of 6.2 years. What the data showed is that in patients who already had an abnormal PET scan, the AI didn't actually add much prognostic value. The p-interaction was 0.039. The PET had already caught the problem. But for patients with a normal PET, the AI acted like a crystal ball. It tells us unequivocally that high-risk plaque morphology, when accurately quantified by AI, predicts long-term disastrous outcomes years before that same plaque actually causes a measurable perfusion defect on a functional PET scan. Essentially, AI allows us to intercept the disease process years earlier than our traditional functional tests.
Building heavily on that theme of early interception, AI is shifting our clinical focus from the lumen of the vessel to the outside of the vessel wall. We are talking about pericoronary adipose tissue, or PCAT, which is rapidly emerging as a revolutionary imaging biomarker. Here is the physiology behind it. Inflamed coronary arteries release cytokines that diffuse outwards and fundamentally alter the lipid composition and the aqueous content of the surrounding fat. Traditionally, this was invisible to us on a standard CT, but radiomics-driven AI can extract these invisible subvisual textural features from standard CCT scans to quantify this mean attenuation. It acts as an incredibly sensitive, non-invasive thermometer for coronary inflammation. It can detect fibrosis and neoangiogenesis, and amazingly, it even allows us to non-invasively monitor a patient's biological response to statin therapy over time. Are the statins actually cooling down the artery? The AI can tell us.
To truly understand the clinical power of this, we just need to look at the Fat Attenuation Index, or FAI score, which was extensively validated in the landmark CRISP CT study. The prognostic impact here is simply staggering. An abnormal FAI score carries a hazard ratio of 12.6 for major adverse cardiovascular events. I want you to think about that for a second. A hazard ratio of 12.6, and this operates completely independently of the degree of luminal stenosis. With AUCs ranging up to 0.838, AI-driven PCAT analysis radically alters our baseline understanding of patient risk. A patient might come to you with a completely benign-looking 30% stenosis, something you wouldn't typically worry about. But if the AI shows their PCAT is glowing with active inflammation, that patient is a ticking time bomb.
Section 6, Perioperative Applications and Hurdles. Bringing it all into the operating theater.
This is where we bring everything we've talked about directly to the sharp end of patient care, the operating theater. For our anesthesiologists in the audience today, imagine for a moment replacing the blunt, generalized tool of the Revised Cardiac Risk Index with AI-extracted, highly patient-specific coronary phenotypes. Precision perioperative cardiovascular risk stratification is not science fiction, it is here. By feeding this dense AI-QCT data into your preoperative planning models, you can know exactly which of your patients carry inflamed, highly vulnerable plaque that might rupture under the massive hemodynamic stress of anesthesia induction or surgical blood loss. Furthermore, generative AI and large language models are right now automating the synthesis of these massive, complex datasets into instantly readable standardized radiology reports, completely eliminating ambiguity. Looking just slightly further ahead, we are entering the incredible era of digital twin technology. By creating a computational simulation of your patient's exact cardiovascular system, you could theoretically simulate how their specific, unique coronary stenoses will respond to induction agents, vasopressors, or massive fluid shifts before you even touch the patient.
But to fully realize this incredible future, we do face some significant hurdles that we cannot ignore. AI algorithms suffer tremendously if they are trained on homogeneous data. We urgently need diverse global data standardization so these tools work on every patient, regardless of ethnicity or geography. We must continue to fiercely push for model interpretability, utilizing the explainable AI we discussed, so that we aren't practicing blind medicine. And of course, we face massive regulatory hurdles to get these advanced deep learning models cleared for real-time, acute perioperative use. But the solution to all of this lies right here, in this room. We now have the computational tools to decode the true underlying physiological risk hidden deep within CCTA scans.
The question I leave you with is this: will we stubbornly cling to our legacy algorithms and visual estimations, or will we relentlessly collaborate across our specialties to bring these life-saving AI models through the hurdles and directly into the operating theater? Thank you all so much for your intense focus and your ongoing dedication to patient care today.